deviate from what I might term the social optimum. They're not considering, sort of the other side of Medicare or Medicaid. I joked with one of the groups I met with earlier today, there are actually two M's in CMS, right? We often forget that idea that we're both, it covers both Medicare and Medicaid, and yet we think very narrowly oftentimes just about Medicare or just about Medicaid. I think this issue is found throughout our healthcare system, but it's particularly apparent in long-term care, especially around Medicare's coverage of acute, post-acute, and primary services, and also Medicaid's coverage of long-term care services. Once again, both programs have this relatively narrow interest to limit their own costs. Nobody's kind of minding the broader shop about overall quality of care. So that's kind of the setup, and I want to take this model and basically first give you some background on dual eligibles. Once again, I'm going to sort of focus on this cost shifting across settings in this presentation, give you several different examples. I'll focus a lot, because a lot of my own research has dealt with cost shifting from nursing homes to hospitals, the issue of nursing home hospitalizations. I'll also talk about cost shifting from home and community-based services programs to hospitals back to nursing homes. Then think about cost shifting from the community to nursing homes for those with mental health needs. Obviously, there's a strong interest in this audience in mental health issues, and so even though this wasn't in the Milbank paper, I want to spend a little bit of time discussing the issue of mental health care as it relates to these conflicting incentives. I'll then shift gears and talk a little bit about some of the potential solutions. Those include capitation, pay for performance, or P for P, which is obviously a very narrow solution as it's currently being structured, but may help to address nursing home hospitalizations. And finally, kind of a big picture, maybe even pie in the sky kind of solution, federalizing Medicaid, which I sometimes think in this political environment is somewhat of a long shot, but intriguing on a lot of levels nonetheless. I'll conclude with some remarks about next steps for both researchers and policymakers. So let me say a little bit about the dual eligible population. This is probably a review once again for this audience, but let me at least say a few words about why this is such an important population. As their name suggests, dually eligible beneficiaries are those that qualify for both Medicare and Medicaid. They receive a lot of policy attention because they are high-cost beneficiaries with quite complex healthcare needs. They're relatively small in number, 7.5 million individuals, but they account for about 1/4 of Medicare spending and about 2/5 of Medicaid spending. So this is a high-cost group. As one point of comparison, Medicare costs are about 1.5 that of Medicare costs for dually eligible individuals are about 1.5 that of other beneficiaries. I don't have the comparable number for Medicaid. I think it would be even larger because of so many of the dually eligible in Medicaid are in nursing homes. Clearly, the quality of care is a big concern for this population. Just to give you one example in terms of primary care, 25% of dually eligible women received a mammography every 2 years relative to 40% of Medicare-only beneficiaries based on some work by Katie Merrill and colleagues and some work by Harriet Comazar and colleagues on the long-term care side. Roughly 60% of the elderly community-based dual eligibles requiring assistance with some activity of daily living have some unmet needs. So both on the primary care side, on the long-term care side, the dually eligible population has some quality of care concerns. So shifting then and thinking about some examples for this dually eligible population, what I argue is that when it comes to long-term care, given Medicare's coverage of certain services, certain settings, Medicaid's coverage of other settings and services, there's often little incentive. That's not to say no incentive, but less incentive or little incentive to substitute care in low-cost settings for that in high-cost settings. No one's kind of minding the bigger shop. You think, I don't want to jump ahead, but in a capitated model with some sort of case management, one might think we'd find those low-cost settings and direct individuals to those services rather than those high-cost settings. So let me work through some examples. The first example is nursing homes and hospitals. So this is an issue near and dear to my heart. I've spent a lot of my time over the last several years analyzing hospitalization of nursing home residents. These are some data from a paper we published. My colleague at Brown, Orna Intrator, is the lead author. We published this in 2007 in Health Services Research. And this state map, this is fascinating. These are just the hospitalization rates from nursing homes for long-stay nursing home residents. And we define long-stay nursing home residents as those in the facility for 150 days or more. On average, the average state had a hospitalization rate for long-stay nursing home residents of 17.4%. You can see, however, quite a bit of cross-state variation. There are states in that high band, like Florida. Junius was telling me just before when we met that Florida seems to rank in the bottom 5 in just about everything. This would be this his words, not mine. So once again, they're one of our high hospitalization states, along with Texas and Illinois, several others. And you can see that as we go down, there are states in that next band between 16 and 19%, like New York and Pennsylvania. We go down to that next level between 12.2 and 16%. We have states like Minnesota, Wisconsin, Wyoming, and then still finally we go down to that last or lowest level of hospitalization between 8.4 and 12.1%, states like Arizona and Washington. So quite a bit of cross-state variation. Some states as high as almost 25%, some as low as 8.5%. And this is total hospitalizations, no adjustment for conditions. Obviously, we'll talk later about preventable hospitalizations. Clearly, you have a very disabled nursing home population. Some hospitalization in some states, the transition to long-stay status is a good one. In spite of Medicare being a federal program, there are differences in post-acute nursing home use and sort of that churning among the short-stay population state to state. So there is some variation there. There's clearly some provider norms that go beyond Medicaid payment or other issues. So Auslander and colleagues have argued that hospitalization lead to a number of bad outcomes. They increase the risk of delirium, falls, incontinence, dehydration, adverse drug events, infections. It's clear at the margin there are some individuals who need to be hospitalized, but it's also clear that if an individual can be treated in the nursing home, that often leads to better outcomes. I think it's also important to note that at least on a per-person basis, we can provide nursing home services, even enhanced nursing home services such as those under Evercare, which offer enhanced primary care for those individuals with pneumonia, for example. Evercare will pay this enhanced nursing home rate of $400. That's far below the cost of a day in the hospital in that study of $1,000. So there's a lot of savings associated with treating individuals in the nursing home rather than sending them down the street to the hospital. That's not for all conditions, obviously, or all scenarios, but in certain instances, there's clearly cost savings. Your colleague up at Florida State, Bill Weissert, always argues to me that he always sees moral hazard problems in long-term care. And Bill, when I presented this work and talked about this work with him, very much encouraged me to include the point below that there's a potential moral hazard problem here, and that's that on a per-person basis it may save money, but sort of paying an enhanced payment rate to individuals who may have been hospitalized may encourage lots of individuals to all of a sudden say, oh, I might be in need of hospitalization, or I guess to encourage nursing homes to say we have lots of hospital-eligible people in the nursing home. So, as always, it's important to think not just about savings on a per-person basis, but obviously on a per-day basis, but also on a program-wide basis. In a recent study that I've talked a little bit about with many of you over the course of the day, I used New York State data to try to estimate on a program-wide basis what are the costs of these long-stay hospitalizations, and along those same lines, what might be the potential savings associated with preventing these hospitalizations. So what we did was that we merged the minimum data set, or the MDS. That's a resident assessment tool that's taken at time of admission and then quarterly thereafter for every nursing home resident in every certified nursing home. In the U.S., we're going to focus this project, these data, just on New York State. and we merged the MDS with the Sparks file. Sparks is a New York State specific database